eating meals regularly and not snacking. And so at that time, being a man-centric life at the time in the 1980s, they calculated that for a 45-year-old man, if that person had less than 3 habits, or equal to 3 of the 7 habits, he was expected to live to the age of 67. 4 to 5, 73, 6 to 7, 78. There is actually an 11-year difference. And when we have continued looking at the data, and what we have realized, come up with the number 12. You can actually enhance your longevity by 12 years or decrease your longevity by 12 years depending on how you live. So morbidly obese Americans with a BMI greater than 40 tend to have a heart attack, an MI, 12 years younger than average. And you can look at that everywhere. This 12-year number comes up. This actually has been reproduced many times. Then there was a paper, this is actually from Sweden, looking at 20,000 men. And they identified that healthy diet, that is a plant-rich diet, alcohol in moderation, no smoking, physical activity, and a healthy body weight was associated with a 79% reduction in acute MIs over an 11-year period. The interesting thing is only the number of those also healthy habits was not very prominent in the population, but that was a real number, 79% reduction in acute MIs, and was actually it was also seen in subjects who had hypertension or hypercholesterolemia. This is actually a German study, and this looks at 4 healthy lifestyle factors, and these were plant-based diet, being physically active. In this trial was 3.5 hours per week of physical activity. This was done in Potsdam, which is actually a place where people ride their bicycle. They look at not smoking and having a normal BMI. So there was actually, if you had 4 factors, you had a 93% reduction in diabetes versus individuals who had none of these sort of good living factors. MI, 81% reduction. Stroke is about 50% reduction, and the same thing for cancer was a 54% reduction, demonstrating the importance of how you live on how you live. Now this is actually from the Interheart trial, if I can make it back there. So the Interheart trial looked at 15,000 subjects with acute MIs, and they compared them with another 15,000 individuals who did not have an MI. What they found was that you could decrease your risk of having a heart attack by not smoking, having fruits and vegetables, exercising, or having alcohol consumption. So that's a 9% reduction with alcohol, 14% reduction with physical activity, and obviously if you smoke, it increases your risk of an MI by 50%. The moment you stop smoking, 50% of your risk goes down. Now, if you add them, you could actually have, that is, no smoking, fruits and vegetables, exercise, and the additional little bit of alcohol, an 81% reduction in acute MIs. That's Interheart. So most of the time in medicine, we're telling people, do not do this, do not do that. The fact of the matter is that except for smoking, there are no do-nots. It's all the do's. Fruits and vegetables, be physically active, maybe have a little drink. So the game plan here is not what to avoid, but what to do. This is from the Leonhardt trial. Again, this showed that individuals after an acute MI on the Mediterranean diet had a significant better outcome than individuals who were on a just Western diet. Noteworthy, this is from the 1980s. About 34% of the individuals in the Western diet were on a lipid-lowering medication versus about 24% on the Mediterranean diet, and still there was a significant benefit. It's amazing what they were doing then. Most statins were not around. Beta blockers were not consistently used. Aspirin was not consistently used in this study.
And the keto diet was still not that.
Yeah, I was
Oh
not.
my gosh.
Now, So I showed you a Swedish study, I showed you a German study, and I'm now going to show you an American study. This is the ARIC trial. It has 16,000 subjects, and they look at 4 things: eating vegetables and fruits, regular activity, physical activity, not being obese, I mean you could be FAT, and not a current smoker. In America, and this is actually the same is true for the Postan trial in Europe, only about 8.5% of their subjects actually had these 4 healthy lifestyle habits. After 6 years, they were able to convert another 8.4. So what happened to the people they converted? They actually had a 40% reduction in all-cause mortality and a 35% relative risk reduction after 4 years, which is pretty significant. Actually, I would have to say that it's better than when I give a patient a statin. Now, also from the ARIC trial, and this is just a beautiful study. You know about the American Association 7, and that is actually not smoking, having a BMI below 25, being physically active, and eating a plant-rich diet. And knowing your cholesterol, knowing your blood pressure, meaning having a normal blood pressure, and having a normal blood glucose, 7 factors. And they actually compare the clinical, what you do at the doctor's office factors, with what you do at home, that is your healthy behavior. And this is actually the incidence of cardiac events. And you can see how behavioral factors related with the clinical factors. This is actually no ideal health factor, that is abnormal cholesterol, blood pressure, and glucose, which is actually not an uncommon finding. But, and this is actually having the 3 factors, the people with the 3 healthy factors and the 3 healthy behaviors have the lower incidence of cardiac events. And as you actually change it, you can sort of get you can get an idea how lifestyle interacts with what we measure at the doctor's office. Now, this is a slide that I'm just showing you sort of like to put it in context. And please don't think that I don't believe that statins are great. I think they're the greatest medicine around for the treatment of cardiovascular disease. And the thing is that when you look at the relative risk reduction and the absolute reduction of cardiac events, comparing placebo and a statin, looking at secondary prevention, looking at individuals at high risk, and primary prevention, you can see that the difference is absolute, and the relative difference is just 30%. This one is really impressive because they had a lot of diabetics and they got a lot of benefit in diabetes. This is 4,000 Scandinavians taking 40 milligrams of simvastatin for 4 years. But for the most part, there was only a 3, 13 to 10, 11 to 8, 7, 8 to 5. So it just, it's great, but it just doesn't do it. It does not eliminate the incidence of coronary artery events. That alone does not do it. So because of the diabetes prevention program, the STOP-D program, we use this as the baseline and from which we actually have developed our curriculum. And you can see that individuals who were placed on the diabetes prevention program, 2 papers published at the same time, one from Finland, one from the USA, New England Journal of Medicine. You can see, and they found the same thing, that with a lifestyle program, there was a 58% reduction in the onset of diabetes in pre-diabetics over a 3-year period. Actually, they had to stop the study. It was a 5-year study because they had to tell the people that were on placebo or metformin that exercising and eating well was good for them. But metformin actually had also an important effect. Now, this is sort of an interesting slide because this study has been done many places, including India. And in India, the relative risk reduction of diabetes with the DPP program was only about 27% and no different lifestyle versus metformin. So the question is, was the Indian DPP study not that well developed or well done, and actually it was a terrible study. It was not as rich in resources as the American one. So, but we have decided to sort of see how we do with the diabetes prevention program in South Asians, and I'll show you that data. So we have created meds. That's actually, that's our, I would say this is our juice. This is actually what we provide to our participants. And med stands for meditation, exercise, diet, and sleep. Now you say, gee, meditation. Well, according to InterHeart trial, 30%, 33% of acute MIs were accounted by psychosocial stress. We also have, there's also data also published in Circulation around 2013 indicating that practitioners of transcendental meditation had about a 47% reduction in MI, stroke, or death over a 5-year period when compared to health education. We have incorporated exercise, diet, and sleep. And that is our lifestyle platform. And this is how we do it. We actually we deploy a personalized coaching model. Our goal is not to motivate. Our goal is actually to make it easy. That is really what we're trying to do. We are not trying to we cannot scare anybody into changing their lifestyle, but if we can make it easy, then we can sort of exert some change. We have an opt-in program, we initiate the process with a clinical educator, and we then attach that person, that participant, to a coach. And we celebrate small steps, and this is sort of how we do it. And that has led to 3 programs. We have our Aim to Prevent, mainly directed at the prevention of MIs. We have the Stop D program. Our goal here is not to manage diabetes, it's actually to prevent diabetes, and for early diabetics, to make them non-diabetic. And I have in my practice a lot of examples of individuals came in, BMI of 24, South Asian 23, a BMI of 21, perfectly normal 2-hour glucose tolerance test, they're no longer diabetic. But they have to go down to a BMI of 21. We also have a Slim Fit program, and that is, we are actually looking at metabolically healthy individuals who actually want to decrease their weight. Now, there has been an evolution in my thinking and the thinking of the South Asian Heart Center. When we started, we would have these heated conversations about recommending weight loss. And I was actually against the recommending weight loss because we actually, allopathic medicine is terrible in helping people lose weight. We can barely do it. Actually, we do if we actually had to go and get a research study to tell someone, to prove that to tell someone to lose weight is appropriate, we would not be able to do that because just telling people to lose weight doesn't work. But we have changed because we have recognized how important and how much this is all driven by the weight. That is, even though imperfect, body mass index is the best easy tool we have. And we have identified that as a driver for both this metabolism and as a driver for coronary artery disease. And we have actually learned how to be able to achieve some weight loss without having to prescribe a diet. So this is what we have done as we sort of interact with our environment. We have our program of outreach. Remember, we had those 4 things at next to our mission statement. We have actually reached 80,000 individuals. We have 12,500 subscribers to our newsletter. We have received donations from 2,000 individuals, and we have interacted with 3,000 volunteers because this center is volunteer-driven. We actually have 8,500 participants who have joined us and for which we are now following in our cohort. We have a research cohort. We have 3 Bay Area locations, and we have participants in 47 states because we actually have now a corporate program, and the corporations are both national and international, and we provide services to all those individuals. We provide continuing medical education training, CME credits. We have actually provided 2,000 CME physicians credits, and we actually receive referrals from about 500 physicians.
'Nationally and worldwide.
Because we are research, we have an interest in research, we have consented 5,500 over 8,500 participants, and we have 2,000 samples in a freezer, in a deep freezer, waiting for future studies. So this is actually what we have done. 58% of our participants have increased their physical activity. 63% of our participants have increased their vegetable consumptions. So this is actually, let me just tell you what we do. We actually recommend, because everybody has a fist, they may not have two, but they usually have one. We recommend that they have 2 fists of vegetables, 1 fist of fruit, 12 nuts daily. And if they're not vegetarian, 2 servings of oily fish per week. That's our dietary recommendation.
Can you say it again?
2 fists of vegetables, 1 fist of fruit, 12 nuts daily, and if not vegetarian, 2 servings of oily fish per week. And that's our diet recommendation. And the fact of the matter is beautiful data on that. You look at Pyramid trial, you know, 1/4 cup of American walnuts from California, eaten in Spain in people who were mainly pre-diabetic, decrease your risk of stroke by 30%. And it tastes good. 57% of our participants have decreased their triglycerides, and please remember, we do not prescribe medications. And actually 62% of our participants have improved their cholesterol to HDL ratio, mainly by driving the HDL up. We have done not that much with LDL because most of the time LDL does not respond to lifestyle changes. The top one is that almost 99% of our participants have been event-free. We have calculated that that number should be about 94, 95%. So I think that the difference has been a service that we have provided to our cohort.
And how do you engage? You don't prescribe medicines. How do you engage with the primary care doctor?
Well, it's out in automatic. I mean, this is, you come in, you're a participant, who's your primary care doctor, and we communicate with the primary care physician. Someone has a high, significant coronary artery score, the physician gets a notice or gets a phone call, and then that individual gets back for, they need statin therapy, whatever. We have identified a lot of people with hypertension, diabetes, and then they go back to their physician.
But you do this remotely too, right?
We do this remotely too, yes, yeah.
By phone?
We do that we actually do by phone and by telemedicine with computer systems, yeah. Yeah.
If I'm reading your denominator is only 2,300 retested, right? So
this is actually retested. This is not today's data. This is actually of the 4,400 participants that were at that time, half of them had completed a year, and then they get retested.
Half of them completed 1 year of the program?
That's for when that slide was generated. This is not, most recent data, because.
So these changes are, what is the sample, I guess that's right.
Well, from that.
85 participants that have been followed up over.
And what is the retest?
So when we are looking at triglyceride and cholesterol levels,
Right.
they have to be retested for that. But for their vegetable and physical activity,
Sure.
we just follow every year.
So I'm just saying that the clinical data is only for about half the sample.
That's correct, because, we have to,
No,
people have to mature.
No, right.
But actually, I would show you a little bit more detailed data on how people have changed with numbers, okay? And the end will be maybe different, okay? And I'll show you that. But this is actually from the Stop Deep program. We have only done 200 participants in 16 batches. We actually have an academic, we actually call it semesters. In fact, they're trimesters, so people enroll in our Stop Deep program. 68% of our participants have reduced their weight over 1 year. 33% of our participants have achieved a 5% drop in weight over the 1 year. And 71% of our participants have actually dropped their A1C. This is just, you could say maybe pilot data from just 200 participants.
How's the retention been on this from perspective?
Well, actually, we have the Stop Deep program, it's a 1-year program, and then we have the Stop Deep Light program, which follows through. So we encourage everybody to stay, to stay connected. Now the question is really, are these changes going to be long-lasting?
Yeah.
The diabetes prevention program, they were long-lasting at 10 years. It did drop, but they were still there. We don't know how, we don't know how we're going to do. The other thing is that we are discovering the language that connects. So this is actually, we are just trying to figure out how to do it. And this is what we have done so far. So I have just shown you our evolution from being a heart disease prevention program to now a diabetes prevention program, and then making metabolism our goal for all our programs. So this is actually, this is as to data of April of 2019, and these are people who really have, even though we have screened and evaluated 8,500 subjects, not all of them decide to stick to do the 1-year program. And I think that we actually have about a 50% retention, maybe a 60% retention, to sort of bring them in and enroll them in, and for them to participate over that 1 year. So
Molina, this is data on all the individuals who completed the 1 year and have followed up over the years.
So you can see that for physical activity, we followed up 38-43, 38-43, 22-46 improved their behavior, and that is about a 58% of our participants improved their behavior, 63 for vegetable consumption. And then people who were not at target, so our target is 150 minutes per week of physical activity and 4 servings, 2 fists. So every fist actually is 2 servings, 4 plus servings of vegetables per day. Not at target, 25-32, who reached target, and that's a 47% improvement in physical activity and a 52% improvement in vegetable consumption. And so,
Quick question.
Yeah.
How do you measure compliance with these?
we ask questions. What happens is many times, for the first year, they are attached to a coach, and they get at least a monthly connection with that coach. And then at the end, we go through the same program that goes at the beginning, and we assess what their lifestyle is at a year completion.
But you don't measure like treadmill times?
No, we don't. We actually don't. We don't. We are not practicing. If we were doing treadmills, we would be practicing medicine. We actually, we are an educational organization providing the resources to help people achieve their physical activity requirements and their dietary requirements, and sleep requirements, which are not listed here,
So
and
this
stress
is-
reduction requirements.
This is their self-perception?
Self-perception, yeah.
But the difference is that we don't give them a questionnaire to fill out. There's a coach who actually goes through the questions and digs into kind of what their dietary patterns are and their exercise patterns. So there's a dialogue that is the same at baseline versus all of the dialogues.
Every month?
Well, for the
the-
first year,
throughout,
and then once every
once
year.
Is the manner of the vegetable consumption, is the quality of the vegetable consumption coded? Because we're assuming that vegetable consumption is a good thing.
Yeah, actually, we
Yeah, right.
wait, we separate, we separate grains from vegetables. So in our language, the grains are not, they do not fall into the vegetable. So if you're eating a grain, then you're not eating a vegetable.
Well, I'm saying if you're eating spinach,
Yes, a vegetable.
yes, and I'm going to my Indian restaurant and I order spinach, I'm not eating the vegetable that you're envisioning me to eat.
Because,
It's
it's 2 fists of
quality.
vegetables
Yeah.
and 1 fist of oil.
Right.
That's correct.
The dash of sugar. Sounds like it doesn't have that.
Right.
It does put
Our
that
most
in.
impressive outcomes are with the vegetable consumption, and that, I'm just wondering, are we measuring truly the right?
Well, what happens is it's an issue of what the measuring comes as a secondary to the recommendation. That is, at one time, we decided, are we going to give recipes? Are we going to be the typical program like, the Weight Watchers that gives you a recipe? We decided that we were not going to do that. But I can tell you that all our participants know that they have to eat 2 fists of vegetables. And they also realize that they have to be cooked vegetables. For example, because if you take spinach, if you take a fist of uncooked spinach and you cook it, it fits in my thumb.
Right.
Now, the other thing is to live well, you need to be a good cook. So we actually
You have to know how to cook first.
Exactly.
But yeah.
So, there are many things that make it difficult. But people do, and we do as we can with the resources we have. This is what we do, and this is what we have
The
shown.
first year of coaching does give all of that as part of the curriculum, so they understand,
The difference between.
and how to cook.
So-
And fried.
So we need to go, but let me just one more thing, and that is, we don't want our participants to have the Wally every weekend. Just like you don't want any patient to have Thanksgiving every weekend. I mean, that's part of our language. But when I'm trying to sort of bring it over to you and give you a discussion of that, that doesn't get translated. They also have, and the other thing is that, to the oil thing is, we're not sure that except for the calories, that oil is that bad for you. We actually, it's not do not eat oil, it's eat the vegetables. And if they come along with oil, we actually preferentially recommend olive oil. But that's not, except for the Stop D program, we tell 1 gram of fat is 9 calories, so you have to be mindful of that, how much oil is in your food. But we don't believe that the oil is the problem. It's the absence of having, vegetables. And at the same time, we recommend that you don't kill the vegetable by overcooking it. And that's what they recommend. This is how we have done with laboratory markers, HDL, LDL, and these are just small changes. But if you think about it, these are participants who were not at their ideal HDL. For a man, it's over an HDL over 40. For a woman, an HDL over 50. And then, after a 1 year part of the program, they went up to their goal. 19% of them changed. LDL, our goal is to have an LDL below 100, and there was an improvement, 38%. Triglycerides actually are easy to change, 42%, and the cholesterol to the HDL ratio in this analysis was 17%, but actually, and that is actually getting to a cholesterol to HDL ratio of less than 3.5, which at that time, which in that case is our goal. So I'm almost done over here, and I was going to sort of show you some testimonials, but I think that they're not necessary. And this is actually where we have placed our research focus. We have looked at abdominal adiposity, and we have compared BMI with height to waist ratio with waist circumference as best as we can calculate it. We have done a lot of this with Jerry Reven, who actually was my mentor at Stanford and who's now passed. And we have found that the relationship between height to waist ratio, waist circumference, and BMI is close to 1, and that BMI will do. We have looked at metabolic syndrome and looking at the relationship between metabolic syndrome and Lp(a), and the presence of metabolic syndrome in the South Asian population, which is actually about 50%, which is very similar to that in the American population. We have looked at Lp(a). We have looked at coronary calcification, and we're writing a paper on this. And we have actually looked at risk calculators. This is where we have published and the conferences we have gone to. We have partners at UCSF. There's a woman who got her PhD at UCSF, is now a faculty member there. We have worked with Jerry Reven, and we have worked with Lata at Stanford Healthcare, and we have worked with the Oregon Health Sciences, who actually had a connection with Intel, up in Portland, Oregon. And this is actually been able to show that we have been able to improve physical activity and vegetable consumption. I think that if we compared the expected ASCVD prediction with our 6-year event-free survival, we have shown some benefit there. And we have actually learned the language to connect with this population. So one thing that we are not, we don't practice medicine. Our participants are not patients. We actually we do coaching, we don't do stress tests,